Good evening, everyone. Visit my site www.painfreepartha.com and my YouTube channel Pain Free Partha. And everyone knows almost like in the circle Pain Free Partha. And now we are going to talk something very basics on brachial plexus anatomy. This is not going to be a high level thing. It is going to be simple basics on brachial plexus anatomy. So whenever I talk anything, I put a big salute to the legendary teacher of 2 centuries. Now I remember, before the era of ultrasound, I was searching for this and gave one block, and I gave around 30 ml or something of 1% or 1.5% like that. And it was not acting very well. Then he came and said, "Man, here is a subclavian artery, and I can just see the brachial plexus." He put in 10 ml, that's all. Those days, I think it was in 1993. And so I just put a salute to him before starting this lecture. Now, the brachial plexus is arising from the union of spinal nerve roots of C5, C6, C7, C8, T1. C5, C6, C7, C8, T1. C5 to T1, C5 to T1. There is no absolutely no C5 to T1. C4 is previously used to say when the twig is more from C4, it is called prefixed brachial plexus. If the twig is, or if the representation from T2 is more, then they call it as postfixed. But what you need to remember is from C5 to T1. The upper roots C5, C6 forms the superior trunk. The upper roots form the superior trunk, and the C7 continues as the middle trunk. C8, T1 forms the inferior. So this is the three trunks. Now this is the posterior triangle of the neck. This is sternocleidomastoid, trapezius, and clavicle. This is the area of brachial plexus. So C5, C6 root forms the superior trunk. C7 continues as the middle trunk, and C8, T1 forms the inferior trunk. Now we can see this is the C5, C6. C5, C6 forms the trunks, and this is going as the sheath and going under the clavicle above the first rib, the brachial plexus, in relation to the axillary artery, covered by the sheath into the axilla. Now here, if you see the roots here, if we want to block the roots here, now we can see how close is to the epidural space. So this is the scalene muscle, this is the another scalene muscle, this is the interscalene groove where the appears. If you deposit lot of drugs here, it is possible to go there. That is what we should know. Now I'm not going to touch about the approaches, only the anatomy. Each trunk, now we have got 1, 2, 3 trunks. C5, C6 forms the superior trunk. C7 continues as the middle trunk. C8, T1 forms the inferior. Now it goes 1, 2, 3. Each trunk forms anterior and posterior divisions. Anterior and posterior. Anterior and posterior. Okay. The anterior divisions of the upper and middle trunk forms the lateral card. Here is the lateral card. Here it is the medial card. The posterior, all the three posterior forms the posterior card. Now I am again telling superior trunk, middle trunk, inferior trunk. Superior trunk is C5, C6, C7 continues, C8, T1. Superior trunk gives us the anterior and posterior, middle trunk gives us the anterior and posterior, inferior trunk gives us the anterior and posterior. This posterior of all the three forms the posterior card, while the anterior of first two forms the lateral card, the anterior of the inferior most forms the medial card. This is about roots, trunks, divisions, cards. Now it is musculocutaneous, axillary, radial, median, and ulnar. We will come. Now the result of this mixing of nerve fibers in that lateral card contains components of C5, C7. The medial card may be from C8, T1. Posterior card is, see from there what nerves are arising. Posterior card is from the posterior divisions of the all the trunks. So all the trunks will have some say in that nerves. So that is why it is sometimes from C5 to T1. So when you say lateral, medial, posterior cord, it means it is in the second part of the axillary artery. In the second part of the axillary artery, lateral is lateral, medial is medial, and posterior is posterior to the second part of the axillary artery. That is what we mean by medial cord, lateral cord, and posterior cord. It is not like trunk. Trunk is superior, middle, and inferior. Cord is lateral, medial, and posterior because it is in relation to the second part of the axillary artery. Now it comes towards the first rib and enters the clavicle. Under the clavicle enters the axilla here like this. Now you can also see here. Now you see here C5, C6, C7 middle trunk, C8, T1 inferior trunk, medial cord, posterior cord of all the posterior divisions. Anterior division of the first two forms the lateral cord. Anterior division of the inferior trunk continues as the medial cord. And these are the divisions. Now we will go to the branches. The branches may start from the ramus. Here, not the trunk is formed. Here is a dorsal scapular and the long thoracic nerve. Here it comes as the long thoracic nerve. This is the dorsal scapula. These are the two nerves which starts from the rami of C5 and this starts from C5, C6, C7. Long thoracic nerve of bell which supplies nerve to serratus anterior. Okay. Now this is dorsal scapula. These two form from the C5 and C6, C7. This is from C5 only. So these are branches before the formation of two branches before the formation of tongues is dorsal scapula and long thoracic nerve. Now we have told 1 and 2. These are the two nerves, dorsal scapular and the long thoracic nerve. Now it forms the superior trunk, middle trunk and inferior trunk. Now we can see in the superior trunk the suprascapular nerve and nerve to subclavius. That is why people are very fond of this block or something like that for clavicle. Nerve to subclavius has to be blocked. So nerve to superior trunk has to be blocked. A lot of other nerves also there, but superior trunk gives off the suprascapular and the nerve to subclavius. Now you see middle and inferior trunks has got no branches. Now I am coming back from C5 has got the dorsal scapular. From the root, the C5, C6, C7 has got the nerve to serratus anterior or long thoracic nerve. In the upper trunk, only suprascapular and nerve to subclavius. In middle and inferior trunk, no branches. Now we come to the guards. The lateral guards gives rise to lateral pectoral nerve. Here you can see the lateral pectoral nerve. This is the medial pectoral nerve. You can see the medial pectoral nerve is actually lateral. The lateral pectoral nerve is actually medial. It is not named after it. It is named after which cord it arises from. Lateral pectoral nerve arises from the lateral cord. Medial pectoral nerve arises from the medial cord. So even it is lateral medial here, which cord does it arise from is only the reason for the name of the pectoral nerves. It also gives of the lateral root of the median nerve and the musculocutaneous nerve and the lateral root of the median nerve. This is the musculocutaneous. This is the lateral cutaneous. The medial root both forms the median nerve. You can see so LLM. Lateral pectoral nerve, lateral root of the median nerve, musculocutaneous nerve or the branches of the lateral cord. Now we go to the medial cord. Medial pectoral nerve, medial root of the median, medial cutaneous nerve of forearm, arm, and ulnar nerve. They call it as 4 M's and 1 U. Medial pectoral, medial root of median. Already we saw the medial root of median coming, the lateral root of median joining here. Medial cutaneous nerve of arm and forearm, and the ulnar nerve. The posterior cord, here you can see the posterior cord as upper subscapular, thoracodorsal, lower subscapular, here the axillary and the radial nerve. Okay. Upper subscapular, lower subscapular, thoracodorsal. Now we can very well see here, some are only C5, C6, C7, C8, and C5, and it may be from radial nerve is from C5 to T1, because I've already told posterior cord has all the things. So C5 to T1, some branches. Radial nerve is coming like this. Axillary nerve. So upper subscapular, lower subscapular, thoracodorsal, radial, and maxillary. These are the branches of the posterior cord. We call it as ultra, upper and lower subscapular, thoracodorsal, radial, and maxillary. Somebody calls it as LLM, lateral cord, lateral root of the median, lateral pectoral nerve, musculocutaneous nerve from the lateral cord. Posterior cord is upper and lower subscapular nerves, thoracodorsal nerve, radial nerve, and axillary nerves. Here we can see the 4 M's and 1 U. Now, if you want to see the anterior and posterior, you can see here this portion is ulnar and median. If you reverse it, it is median and ulnar also. Some part of radial also will come. Here it is median. This is radial in the dorsal side, radial and ulnar. In the palmar side, median and ulnar. Ulnar 1.5 fingers remains the same. The 3.5 fingers, palmar is median, posterior is radial. Now, musculocutaneous nerve supplies the biceps and comes lateral cutaneous nerve of forearm. That is why whenever I saw a surgeon putting an incision here, I block the musculocutaneous so that he can put the knife immediately. So this is the lateral cutaneous nerve of forearm, is a continuation of the musculocutaneous nerve. The radial nerve supplies here the medial cutaneous nerve of arm, medial cutaneous nerve of forearm. All these are branches of the medial cord. Here there is portion which is supplied by the axillary nerve, that also supplies deltoid, and intercostobrachial nerve. All these things we should posteriorly mainly radial. Posteriorly mainly radial. Axillary supplies the deltoid, musculocutaneous supplies the biceps, radial supplies the extensors, median supplies the lateral palm, and also lobe. Lateral two umbilicals, opponents pollicis, abductor pollicis brevis, and flexor pollicis brevis superficial, what they call as lobe. Intraossea is supplied by the ulnar, and medial hand is supplied by the ulnar. So this is axillary deltoid muscle, musculocutaneous flexor, radial is extensor, triceps is radial nerve, median lobe, ulnar is intraossea. Randy Travis drinks cold beer, roots, trunks, divisions, cords, and branches. Median, axillary, radial, musculocutaneous, and ulnar. Now, if you want to see, now this is the axon. The axon has got a myelin sheath. This is the nodes of Ranvier. So, saltatory conduction. Nodes of Ranvier. This is the myelin sheath. If it goes in here, and this is the endoneurium. And the endoneurium goes in thin, and this is covered by so many endoneuriums are covered by perineurium, and this is called a nerve bundle or a fascicle. And these lot of fascicles will be covered by a so-called epineurium. Now I am not going into the controversy of which is intraneural, all these things. I just want to know you the anatomy of epineurium, perineurium, and endoneurium. Axon, myelin sheath, endoneurium, perineurium, epineurium. This is the fascicle, this is the interfascicular area. There is the veins and arteries. The brachial plexus, right, the most important thing is about the sheath. The connective tissue extends from the prevertebral to the axilla. That is what they call as tunnel. There is a lot of controversy about, because of the development of technology of ultrasound, the sheath can be seen very well. Something like that. I am not going to go on these things. Yes, if you put it here beneath the sheath, yes, it is likely to come here. If you put it in the supraclavicular, 15 ml, you can see it here. Sheath is continuum. That is the advantage of the so-called brachial plexus block, giving in different places. Now, this we could call it as root, trunks, divisions, cords, terminal branches. Now you see if you give here it is interscalene block. That is, I'm not going to the details again. It is simple. Here if you block it is interscalene. Here if you block it is supraclavicular. So because it is above the clavicle. And here if you block it is infraclavicular. And here it is axillary. Clavicle below infraclavicular. Clavicle above supraclavicular. This is where you put as interscalene. So trunks is the most important part of supraclavicular and roots is the space of interscalene. Cords is where you can see is infraclavicular and costoclavicular, and divisions are about this thing. Divisions are cords. Yes, we can see here some sort of infraclavicular also. So there is a confusion now. The axillary artery is here. This is the classical infraclavicular. All the things are lateral cord, medial cord, and posterior cord. Now, if you go laterally, you can see the lateral cord coming here, posterior cord is there, medial cord. So they form the cluster lateral to the axillary artery. So this is the serratus anterior, the subclavius muscle. We should know the subclavius muscle, axillary artery, and the serratus anterior. Yes, we can pick up the three cords. This is what is called the costoclavicular. Now this is a classical M pattern, what they call as musculocutaneous 2, and then the ulnar nerve, all these things, the M pattern at the end. This is not needed that we have to have M pattern. Is the M pattern classical? There are a lot of variations. Thoracodorsal originates from the axillary nerve. Ulnar nerve has got branches from the lateral cord. Median nerve is branches from musculocutaneous. There are so many variations. Now we can see there are two branches only from the medial cord. And musculocutaneous nerve branches here. Axillary area 1 plus 1 is never is equal to 2. Now you can see the classical, what do you call it as? In ultrasound they say is as conjoint tendon, axillary artery, biceps, musculocutaneous, median, ulnar, radial. You can see here the axillary vein between here, above here, and all these variations. What is common is this. Axillary vein is in between ulnar and radial. So vein is in between ulnar and radial. Musculocutaneous is already separated. Or sometimes the right side shows higher variations. How to test we have given? Push, pull, pinch, pinch. It's very simple. Push means radial nerve, pull musculocutaneous, pinch in the this side. Hypothenar eminence, thenar eminence. Hypothenar is ulnar, thenar is median. So four nerves. Push, pull, pinch, pinch. This is the classical test of push is radial, pull is musculocutaneous, pinch is thenar is median, hypothenar is ulnar. Flex elbow, extend elbow, skin over thenar, and hypothenar eminence. Now we will go to what is the intercostobrachial nerve. Is actually a lateral cutaneous branch. Here you can see this is the intercostobrachial. Lateral cutaneous branch of T2. It originates in the second intercostal space and pierces the intercostal muscles and the serratus anterior into the medial wall of the axilla. This is the problem with intercostobrachial. Why I am telling intercostobrachial or ICBN? Intercostobrachial is not part of the brachial plexus. It is from T2, but it supplies some part of the hand here. So here you can see the ICBN. There is a medial brachial cutaneous nerve. ICBN may be one or two branches. Here it's from here it goes and supplies this area. So if your incision is going to be there, or sometimes they say ICBN need to be blocked for decreasing tourniquet pain. Now the block I will just touch upon. It is not about scan or ultrasound or anything like that. Interscalene is mainly shoulder surgery, clavicle and proximal humerus. This area. Supraclavicular, what they call it as spinal for upper limb, arm, elbow, forearm, hand, anything. They call it trunks and divisions. Costoclavicular, 3 cords gone. Ideal is catheter. In infraclavicular, cords around the axillary artery. Axillary terminal branches. Elbow, it is not very suited because sometimes the musculocutaneous may not be blocked. So elbow, it is questionable. Axillary. All others, supraclavicular and costoclavicular, are ideal for almost they call it as spinal of the upper limb. So what is it? Brachial plexus comes out from C5 to T1 and forms trunks, divisions, cords, and branches. Nerve roots, trunks, divisions, and branches. They say spinal of the upper limb was supraclavicular prior. Now they have switched over slightly to costoclavicular. Thank you. Visit me YouTube at Pain Free Path. Thank you all.